Hi, I'm Jane Simpson. I'm from Lancaster University and I'm Professor of the Psychology of Neurodegenerative Conditions.
Good morning, I'm Maria Dale and I'm a clinical psychologist. I'm also trained in neuropsychology and I work in a specialist HD service based in Leicestershire, and that includes an inpatient service and a community multidisciplinary team for families affected by HD. We work across all stages of the disease. And I'm involved, Jane and myself are involved in the Euro HD network also, in terms of trying to promote psychological interventions and approaches for people with Huntington's.
Okay, so in terms of what we'd like to achieve today, we're aware that there are lots of people here who are coming from different perspectives. So it's been quite tricky for us to work out exactly what might be most useful. But we've had a go at trying to put forward an agenda. So our aims of today generally are to kind of talk about how psychology can help people with Huntington's throughout their life. We'll be touching on some of these issues in much more detail than others. So that obviously issues around genetic testing, psychological issues through life, psychology, therapy, mental health support, family relationships and end-of-life issues that we'll be talking about. And we'll also be talking a little bit more about access to psychological services, because we're aware that for many people this is a very live and pressing issue. So Huntington's disease, this is only a very quick summary, because we're aware that for many of you this will be very well understood and known information. So Huntington's disease, a genetic neurodegenerative condition with diagnosis based on involuntary movements, sometimes called chorea, coordination difficulties and issues relating to swallowing and speech. It results from an expansion on the Huntington's disease gene, which causes damage to the basal ganglia and specifically the corpus striatum, which is one of the reasons why movement issues are so pronounced, especially early on. Around 12 people per 100,000 in the UK. Typical age of onset between 35 and 45. Average of around 20 years from diagnosis to end of life. Predictive testing, which has been available for what, about 30 years now, is available, but there is a relatively low uptake, often less than 20%. Counselling is available at the predictive testing stage and can help people make decisions and help services think about how best to offer support. There are just some issues around terminology that I'm sure everybody's aware of, but it might be worth just kind of reiterating what we are understanding by these terms. So at risk is someone who hasn't had the test but might be at risk of Huntington's disease due to a presence in the family. Premanifest is where somebody knows that they carry the Huntington's disease gene but are yet to develop symptoms, and manifest is where people have the Huntington's disease gene and are showing symptoms. In terms of psychological difficulties, we've split these out into two sections really. So these are what you might call the kind of diagnosable conditions. These are the ones that appear in kind of psychiatry manuals such as DSM, Diagnostic and Statistical Manual. So these might occur at any point in each individual or not at all, but these are the possible diagnoses that people might get. Depression, so that's obviously low mood, anxiety, which is very common, mood extremes, feeling very high, feeling very low, what's been called irritability and aggressiveness, apathy, the feeling that you just don't want to do anything. We know that there's an increased risk of people considering suicide and taking their own life. We know that there's also a higher level of people with substance abuse problems. There are indications that some people with Huntington's disease, maybe a little bit later on in the disease, will have hallucinations, and obsessions and compulsions have also been reported quite frequently as well. We're not going to talk a lot about cognitive difficulties in this session, but that isn't to say that we aren't aware of their existence and the difficulties that they cause people. So cognitive difficulties, specifically in working memory and executive function, that's our kind of like ability to think and do things almost like in the moment, commonly reported at both pre-manifest and manifest stage. At the manifest stage, people often have a wider level of cognitive impairments, and those cognitive impairments tend to be more severe as well. And people approaching the end of life will often have a dementia as well. However, in addition to what we call those kind of diagnosable psychological difficulties, we also know that there are other issues that people have to deal with as well in their life. You know, we often have people reporting shame, guilt, especially if perhaps they might have had a test and it's been negative. There can be guilt involved there. We often talk about HD as a family disease, so a lot of the emotions that people express at this time, the difficult emotions, can be in relation to that family dynamic. Also, we're aware of attachment issues. It can be difficult growing up in a HD family, and sometimes there are issues around attachment. Self-esteem of people can be repeatedly and quite considerably knocked. We also have people expressing a lack of control and uncertainty about the onset of symptoms, and with that lack of control and level uncertainty, that can lead into other kind of psychological difficulties as well. So, for example, anxiety. You don't know exactly when you might be experiencing the onset of symptoms. If you're at a pre-manifest stage, that lack of control, uncertainty can obviously result in heightened levels of anxiety and checking for symptoms, sometimes called hypervigilance. There can be parenting issues in people within the family, parenting difficulties. We know that people with HD often experience a lot of stigma and discrimination, and we're well aware of the negative effects of public stigma on how you feel as an individual. And loneliness can be an issue as well. You know, there's research which has talked about HD being a kind of a secret within the family almost, and people can feel that can close them off from other people and mixing in the way that they might want to. So just moving on.
Sorry, Jane, I've just got a screen freeze.
Okay.
I can pick up on the next part while we're trying to deal with the slides, if you'd like. So I was going to be running through potential psychological approaches by stage of disease, and I'm aware that there's family members in the webinar, and some of whom might be newer to Huntington. So I guess I just wanted to say that I will be referring to some psychological issues that occur later on in the disease, so to make people aware of that. So as mentioned earlier, I work in one of the, I guess, unusual services in terms of that we are very specialist, and we see people at risk in our service, and right through to people at the end of their lives. And I'm aware that that is unusual, and I'm very aware also that as I go through some of this, it is very difficult across the country in terms of what's available and what's not, and what I and the host psychology team in Leicestershire can offer isn't readily available everywhere. But I guess it's going through what the types of therapies that might be appropriate for people with HD at the various stages. So, as mentioned, we do see people at risk in our service, so we want to be inclusive, though we appreciate that a lot of people who are at risk won't necessarily be able to access HD-specific services. So we do obviously only accept people to our psychology service if the presenting issue is HD related. So I guess I obviously only see a certain set of people who are struggling. So the majority of people I might see, the majority of people at risk decide that they don't wish to undergo predictive genetic tests for HD. But some people really struggle living with this, and some people will say that they feel that they aren't robust enough to take the test. And so in my experience, among the people I've worked with, many at-risk people might live as if they have the genetic expansion, and HD can overshadow their lives sometimes and their choices. So some people might see themselves as having a limited lifespan, or decide not to have children on the basis of their 50% risk or 25% risk. And many, obviously, as you know, might also be in a caring role for other family members with Huntington's while having their own risks. So that, of course, there's all that to cope with. So at this stage, I guess people might benefit from a range of psychological approaches, and I've got a list here of different psychological therapies that people are likely not to be familiar with. And so I'm going to just briefly give an overview of some of these approaches. So just moving on to the next slide, I'll explain what some of those are. If we can move on to the next slide, Ruth. I'm not sure if it's freezing again.
Sorry, this is not working out. I will just...
It's okay. I have a set of slides I can refer to if need be. So if I talk about cognitive behaviour therapy, this might be something that people are aware of or have heard of. There's a lot of self-help books out there. And so as the people I see who are at risk, and people who are pre-manifest, mainly have experiences or issues relating to anxiety and low mood, an obvious choice is to use aspects of CBT, or cognitive behaviour therapy, as that has the most evidence across the broader population. So while we'll be speaking later about some of the evidence being lacking in Huntington's, and that's just literally because there's not enough studies that have been done, what I might do is use generic worksheets for anxiety and depression and some of the resources there, but I'll adapt it very much for the issues of the particular concerns of people with Huntington's and fears, or from families of people with Huntington's, and fears that they might have about having it. So CBT, just briefly, as an overview, it holds that emotional distress and behavioural difficulties arise from unhelpful thoughts, which comprise of general beliefs about the world and the self and the future. So the therapy is largely based on the assumption that changing the way we think will help reduce distress and problematic behaviours. So moving on to another approach. So relating to CBT are what we call in psychology third wave therapies. One of these is called acceptance and commitment therapy, or ACT. And I know this has been used among people who experience other neurodegenerative disorders, and there's some evidence out there. But I personally, because sometimes it doesn't feel appropriate to use some of the language of CBT, I mean, talking about maladaptive thoughts and those kind of things, I think sometimes people at risk or various other stages of HD find that ACT can fit really well. So it uses some of the principles of CBT, but there's more of a focus on values and acceptance that life is difficult and we do undergo struggles as human beings. So the focus of ACT aims to improve individuals' acceptance of distressing thoughts, beliefs, sensations and emotions. And the idea is that will bring about behavioural change and consequently improve people's quality of life. And there's an emphasis on acting upon values that are most important to the person and then designing behavioural changes which direct people towards living those values that they hold. So I don't know if we've any joy. Oh, thank you. So compassion focused therapy it's another third wave therapy that has gained popularity in the psychology population. And CFT, that aims to promote a mental and emotional healing by encouraging people in treatment to be compassionate towards themselves and other people. So compassion both towards the self and others is an emotional response believed to be an essential aspect of well-being. So personally, I'm less familiar with this approach. I do want further training on it, but from what I know, I think that it does have some applicability to Huntington's, and I'm aware that some other psychologists are working with this approach among people with Huntington's. So mindfulness-based approaches. So this mindfulness has become increasingly popular in society in general. So many of you may engage in mindfulness practice already. It actually forms part of ACT, which I previously mentioned, and some other psychological therapies. So mindfulness-based approaches focus on bringing the attention to the present moment and accepting feelings, sensations, emotions, without judgment, and that might include the experience of illness. And when these approaches are developed for neurological conditions, that may be about acceptance of discomfort around that and the physical changes that occur, and then focusing on relaxation and the appreciation of abilities and resources which remain. So there's mindfulness which incorporates elements of cognitive therapy, so mindfulness-based cognitive therapy, or it might focus on stress reduction as well. So psychoeducational approaches focus on developing individuals' understanding about their disease and how they live with the condition. So the aim there is to empower the individual to manage their condition and their own reactions to it more successfully, and consequently improve their well-being. So some programs may include elements of CBT and the development of stress coping strategies, social skills training, may involve role play sometimes, or relaxation skills. So the content is often tailored to the specific condition, and later on, when we look at the guidance that Jane has led upon for the British Psychological Society, we'll look at and see that there have been studies on Huntington's focusing on psychoeducation. So many people might be familiar with relaxation techniques also. There's certainly lots of resources out there on YouTube and the like. And so relaxation-based interventions may focus on relieving muscle tension, to help reduce anxiety predominantly. And techniques may involve progressive attention to the muscle groups, tensing and releasing in turn, and they may be supported by relaxing music or guided narratives to assist in exercises. And I ought to add as well, this relaxation can also involve more imagery-focused guidance, such as generating a relaxing image, as well as the muscle relaxation. So just briefly, narrative therapy. So this has started to be used for people affected by Huntington's, and it's a form of therapy that aims to separate the individual from the problem and allows people to externalize their issues rather than internalize them. So it relies on the individual's own skills and sense of purpose to guide them through difficult times. And like ACT, which I mentioned earlier, there's a focus on personal values. So lastly, sorry about this whistle-stop tour through some psychological approaches, but it's just to gain some familiarity, and you'll have the slides afterwards if you wanted to follow up on some of this. But family or systemic therapy, that can involve couples or larger family group, and this encourages family members to express and explore difficult thoughts and emotions safely, and to understand each other's experiences and views, and to appreciate each other's needs, and to build on family strengths and make useful changes in their relationships and their lives. So if I go back to the HD stages, so there's some familiarity there with some of those approaches. So I'd say within my service, the majority of my referrals are for people in the pre-manifest stage. So people seem to struggle, particularly as they approach the expected age of onset. So common psychological issues among people that I meet can be around adjusting to the positive predictive test. So while many people might cope initially or around the time of counselling, for genetic counselling, the result for some can be catastrophic, and for some people sometimes that can be delayed after initially coping well. And I guess we're aware there can be this gap in services across the country that we really want to be able to do something about, that for people who have been through genetic counselling, but then there's a gap before maybe they may not be picked up by services until they're showing some of the motor symptoms of HD. So often discussions that I have might involve anxiety around people's future decline or thoughts of dying, and worries about the impact on their children and the family, and telling other people about Huntington's, whether that be, you know, partners or employers and the like. And when people get the positive test, they obviously, as Jane mentioned earlier, can be understandably quite vigilant to the signs of HD starting. And, you know, people can interpret normal clumsiness or memory lapses as a sign that the disease is started, and that can be very anxiety provoking. And consequently, you can find sort of feedback loops where that can make people more clumsy or have more memory problems. So anxiety plays quite a role there. And people often raise to me ideas around euthanasia and taking their own life in the future, and often when symptoms become advanced. And I guess, although things like Dignitas are mentioned, I've personally not known anyone to follow this through, and I've found as I've worked with people over time that they come to accept things and adjust, but certainly you know, they can be a feature of our conversations. So I guess the similar therapeutic approaches to those that I mentioned already that would be applicable to people at risk. And I guess of note is also how conversations about future planning might be offered or be useful. So in my experience, I guess people mostly only want to dip their toes into the idea of making advanced decisions because it seems so far off. But I would say it can be a good time as people have communication and cognitive skills to be able to think these issues through and be able to state their wishes for the future. So in the early manifest stage, I'm just looking at time, early on in the disease, once the motor symptoms have started, then common issues or themes that I might work with people include coping with the clinical diagnosis, adjustment to that, potentially loss of roles, and sometimes, you know, in addition, coping with the loss of other family members who may be affected by the disease too. So grief is a big issue among people's families, and frustration, anger, why me? Which is very understandable. So I guess we, as a psychologist, may look at it from those perspectives as well, and not just from the kind of the diagnostic perspective or discussions around irritability. We may be looking at those reasons, those psychological reasons why people might be frustrated. And guilt, as Jane mentioned, obviously I'm sure people know about passing on to children and those changing family dynamics, you know, whether people can feel a burden to others. There can be changes in people's self-confidence, and I'm sure people are aware as well about feeling self-conscious or embarrassed about movements, and especially when the public may not have an appreciation around Huntington's. So again, the therapeutic approaches that I've mentioned already can often be useful, and I might need to start adapting some of the therapy. And this is where I guess it's quite difficult when people haven't got that kind of understanding of neurological changes and cognitive changes. But I might adapt some of the therapy, so more maybe simplifying of ideas that are used in therapy, more repetition, slowing down the pace of the work, or using reminders on, like, alarms on people's phone, assistive technology, or written prompts, or using some of the techniques of partners maybe might help support people to use them. And I think hope is really a part of our conversations as well. And obviously, I think people know that research, engagement and activity can help. And I think even if that's about people coping with the guilt that they feel for passing on things to the next generation, to engage in research, I know a lot of people find that really, really helpful. And just generally to help people deal with loss and grief, and that's anticipated loss, I guess, as well as past losses. So thinking about people's imagined futures and helping them cope and talk through those things. So in terms of sort of the mid-stage of Huntington's, the focus in my work and what psychology might be able to offer is sometimes when people can engage in sort of behaviours that other people might find distressing or frustrating. I guess people might not be aware themselves, but for some people can become aggressive. Some people, as I'm sure people are aware, can become very fixated on things and repeat themselves and not necessarily find it easy to initiate activities, and can be quite impulsive at times, or just not have that filter really in what they might say or do. And because of people might have difficulties with self-awareness of the risk issues can increase, such as falling or burning themselves. So I guess there can be also helping people to adjust to a new identity. You know, for example, if they have to start using mobility aids, that's difficult for people sometimes, or that loss of independence, or changes in sexual relationships and intimacy. And as I mentioned before, people become distressed by sometimes the world out there, you know, when people can perceive people with HD as being drunk, when they might slur their words or have the movements. So again, how psychology might help people is, I think, ACT-informed work. I know I keep coming back to ACT, but I think it can be really helpful. And so looking at meaningful activity based on person's values and focus on what people can do and help with acceptance and adjustment to changes. I find relaxation methods can help, and often now I think more focus, certainly in how I spend my time, is on supporting partners or carers, and might help in terms of psychoeducation around cognitive changes, and in particular how that relates to people's presentations. You know, how things like apathy and initiation might be perceived as laziness, for example, and to kind of think how those changes people can't help how they are acting. So and often helping people who are caring for people with HD care for themselves and cope with the living grief. And you know, we've run carers groups as well, just like the HDA offers some excellent support there as well. So I'm just aware of time. So in the later stages, I guess a lot of the work I do is mainly indirect. I think the relaxation methods can be good. Again, certainly a lot of my efforts are supporting staff, say in the inpatient work that I do. So we might look at ways of looking at triggers that might lead to people's distress, and to use proactive strategies to help reduce the chances of distress, to look at life story work with people, and to offer psychological perspective in multidisciplinary team reviews, and help team formulate people from a psychological perspective, and they're focusing on dignity, interests and activities based on people's values are central. So just thought I'd briefly mention some of the dilemmas and implications of working with a family disease. Jane did mention some of these already, but obviously to test or not to test, it's a massive and heartbreaking decision for anyone to have to make, and there's often pressures within families to take the test or not take it. But as we know, it's a very individual decision, and you know, so sometimes it's supporting people with that. And related to this is that people can experience multiple losses of family members, especially in larger families. Having children, there's, you know, family conflict that can emerge within that, and some people have very strong opinions about that, and that can be tricky. I guess there can be dilemmas as professionals, you know, if people don't want to tell their children what we do about that, and visions of the future. Obviously, people, because the family nature of Huntington's, people think that they will be just like their parents or grandparents, but that doesn't necessarily follow at all. But there is that fear there, and you know, being parented by an HD parent can sometimes lead to adverse sort of childhood events, just by virtue of people's symptoms. Obviously, family secrets can be revealed as well, which can be tricky. And also, I think just from a professional point of view, I think when we're working with a number of people from the same family, there can be challenges there in terms of confidentiality, for example. So I'm just going to hand over again to Jane, who's going to run through the guidance that's been published.
Hi, yeah, thanks, Maria. Okay, so I'm just going to talk to you a little bit about a recent document that the British Psychological Society, the BPS, and ourselves have been involved with in terms of providing guidance for anybody interested in psychologically informed work for people with a number of different motor neurodegenerative conditions, and including Huntington's. So as well as the actual guidance, which is free to everybody, you can download a short version, or there's a full version available as well, with lots and lots more information. There's also an updated review that's been published, this particular review, Psychological Interventions for People with Huntington's Arms, which is in the Journal of Huntington's Disease. So the in this particular review paper, we were looking at kind of trying to extract all those studies, regardless of quality, which reported one of the kind of psychological interventions that Maria's so ably just described to us, and whether it was successful or not. Now, we did this for 4 motor neurodegenerative conditions, so for people with Parkinson's disease, people with multiple sclerosis, people with motor neuron disease, and people with Huntington's disease. And it was very striking about the limited evidence for people with Huntington's disease, which was similar to people with motor neuron disease, but much, much, much less than people with multiple sclerosis, and much less than people with Parkinson's. So we started with over 1,500 articles. After screening, that number came down considerably. We looked in much more detail at 15 articles, but we only could include 9. And there was only 1 RCT, so that's only 1 randomized control trial, which is often seen as being the most high quality type of research, looking to see whether an intervention has worked or not. So this number is shockingly low, and it's obviously something which is of huge concern to all of us. While the lack of psychological evidence doesn't stop people receiving psychological services, it does have an effect in that we always like to have more information about what kind of therapies work best for what people, and research can help us to do that. So it doesn't stop us providing psychological therapies, but the lack of evidence is important in terms of informing us how we might best do that. So in terms of what we found, as I say, this is going to be quite a short little section because we didn't find much at all. So in relation to anxiety and depression, there are no randomized controlled trials, the highest level of trial. There was some evidence of individual cognitive behavior therapy, which Maria talked about previously, with people who were at pre-manifest and manifest stage, but we are talking very much about preliminary evidence. In terms of irritability, there are no studies of any specifically psychological interventions which targeted irritability as a specific outcome. There was some evidence for the effectiveness of sensory modulation and progressive relaxation, which Maria's discussed, in reducing aggression, but there was no difference from a preliminary randomized control trial exploring multisensory stimulation against simple relaxation for aggression. So again, we're still very much in the dark. In relation to apathy, which is a difficulty that many people experience, we've got no randomized control trials. And we have no specific studies which have looked at interventions specifically targeting apathy. There was a study which used what was called remotivation therapy in improving interest and awareness, which was, I suppose, are kind of psychological constructs, processes which are similar in a way to a lack of apathy. But again, very little research in this area. We know that coping is really important, how to cope well, how to develop those skills that are going to be really important to try and manage all the different challenges that people are going to be experiencing during their life. No studies available on what coping strategies work best. There was some indication that narrative therapy, which Maria talked about, could be useful, but this was specifically around the genetic counselling stage rather than later on in the disease progression. So again, the what is missing slide could be a lot longer than this because essentially everything is missing. So we know that CBT can be effective for people with anxiety and depression. Generally in society, there's a lot of emphasis on the use of cognitive behavioural therapy, but very little for people with Huntington's disease. We know that irritability and apathy have often been discussed as issues which are of real concern to people, but we don't know what best can work for those particular difficulties. There's nothing on obsessive compulsive disorders at all, and very little evidence on what we call third wave therapies. So these are the therapies that Maria talked about, like mindfulness and acceptance-based therapies, compassion-based therapies, and we think that they have got an awful lot of potential to help people with Huntington's. There is a little bit of evidence suggesting that mindfulness is well tolerated people with pre-manifest Huntington's disease, but that particular study was a feasibility study rather than looking at specific outcomes in a lot more detail. And unfortunately, there's no evidence at all really on psychological approaches, psychological therapies for people in the later stages of HD.
So I think we just briefly wanted to provide a little bit of information about professionals who might offer psychological approaches. Just we didn't want to assume that people actually knew who we were. So both Jane and myself are clinical psychologists, and just to say that it takes a minimum of about 6 years training and often more, and we're doctoral level trained, and we are trained in a kind of core therapeutic approaches, a number of them, and then what we do is we offer bespoke interventions based on individual need, and then you can check if someone is registered on the Health and Care Professions Council, so psychologists need to be registered there. And so just to mention sort of just the difference, because this does come up sometimes about what's the difference between psychologist and psychiatrist, is that we're trained to understand human emotions, thoughts and behaviours, while psychiatrists are medical doctors who then specialise in psychiatry. So just to explain that difference. I'm aware we do have further mental health specialists who I work alongside with, like nurses, OTs, who offer very, psychological work as well. But just moving on to the next slide briefly, again, just in terms, I'm not going to do any justification regarding other psychotherapists and counsellors who might also offer psychological therapy and might be often in private practice as well, but also in NHS services, and that would be especially cognitive behaviour therapists. But I guess I wanted to alert people to that if you're trying to identify someone to offer help, then some titles aren't protected. So you might want to check whether the person, again, is registered to practice. So, and we've got the websites there for the British Association for Counselling and Psychotherapy and for the UK Council for Psychotherapy as well. And just back to Jane for the pathways.
Yeah, I can imagine that a lot of people on this call are thinking, how do I access psychological help? And we are extremely sorry to say there isn't a really straightforward answer for that. It's not clear around the country, there's no consistency around the UK, and we're well aware that this is a massive issue for a lot of people affected by Huntington's. We were asked to try and provide some clarity about this, which is what we're trying to do, but the more we've looked into it as professionals, the more confusing it has become to us as well. So what I'm about to say just needs to have a massive caveat, which is that there will be a lot of variation here in what I say, and we can't provide a kind of, this is exactly going to be the case for everyone, because it is so different. So in terms of understanding those differences, then obviously one of the issues is who's actually doing the who is actually doing the referring, and what is the perceived level of complexity of the difficulty that somebody affected by HD is coming through to. In mainstream mental health services, is what's called a hierarchy of services. So you have kind of often guided self-help at the bottom of the hierarchy, which is accessible for people with what are considered as less distressing levels of difficulties, moving right up to kind of inpatient care for mental health problems. And for people with Huntington's disease, that hierarchy, that pathway just doesn't seem to be available in the same way. For people who are not in contact with HD specific services, then their GPs can refer to generic adult mental health services, or sometimes directly to a neuropsychology service where one is available. But this is very, as we know, variable across the country, and I'm sure you've all had different and probably very frustrating experiences here. There can be referrals to what's called IAP, that's improving access to psychological therapies service, which is predominantly a CBT time-limited service. Often the services aren't called IAP, they might be called Minds Matter or Feelings First or something like that, and most local areas will have them. However, we do know from talking to people with HD that often referrals to those kinds of services have not been successful, and for reasons that perhaps aren't particularly clear, referrals have been rejected. We also know, though, that that particular service, IAPT, is trying to develop a neurological pathway, and so we're hoping that when that pathway, that additional training is available, then perhaps that service might be more available and more helpful for people with conditions such as HD. Okay. If people are already in contact with the HD service as a specialist hospital, then there are a number of options that the person providing your care might be able to refer for you. So, for example, that there are psychology services based at hospitals, sometimes health or medical psychology, as it's sometimes called, or neuropsychology, that are hospital based, which if you have a consultant neurologist or psychiatrist who's responsible for your care, if you're showing symptoms and are in contact with hospital services, there is a possibility there for referral through that route. For later on stages, there's also possibly psychological support available from young onset dementia services as well. Now, there are in some specialist NHS HD centres a specialist psychologist. So Leicester is incredibly lucky to have Maria there as their kind of in-house clinical psychologist, but we're aware that a lot of even specialist HD centres don't have a psychologist as part of the team. And in terms of other options, then sometimes specialist services can be run by charities, and they might include psychology as well. We're aware of a large kind of charitable service in Scotland, in St Andrews, which can provide psychological and neuropsychological services. So just kind of where we're now, really. I'm just going to do this briefly because I'm aware of time ticking away. You know, there's so much to do here. We need more evidence, we need more research, we need to find out psychologically what works. But that's kind of only going to take us so far. After finding out what works, we also need the people who are able to provide that support as well. So, you know, we need to be pushing and campaigning for more mental health support, whether that, you know, I suppose including at all levels at the moment, given the lack of much at all. So, you know, IAP neurological pathway might be useful, but it's not going to be useful for everybody. We know that. And so we need to think across the board in terms of creating a pathway of psychological support. We know that it's really important for people to get support from and information from local associations. So obviously we're here as part of the Huntington Disease Association, and we know that they provide a great level of support in terms of trying to help people navigate some of these systems. Maria and I, as I think we might have mentioned, are also part of the European Huntington Disease Network Psychological and Approaches Working Group, where we try to coordinate with other colleagues across Europe about addressing some of these issues. And we just put our website address there in case people want to contact us. I think Maria has just put together some self-help resources here for people who might be interested in that.
Yeah, I mean, just briefly, I'm aware that there's, again, a lack of HD specific self-help resources. It's certainly a project we're working on and want to do that and make things more relevant. But yeah, I mean, just in terms of what I use, the Northumberland Tyne and Weir self-help books, they're great. They're generic, they are general, they're not HD specific, but they're useful. And again, with Mood Juice as well, there's audio guides as well. There's Get Self-Help, and there's, in terms of apps, we know that there's a lot of apps that people can use as well. And looking on the NHS apps library is a good one to know, because they can be quite variable in terms of what is offered, but they'll be approved more, or at least be endorsed in some way by the NHS. I think in addition to what I've got there, or just because I've mentioned ACT a bit as well, Russ Harris, I think you can find worksheets quite easily on ACT on the internet, and also some YouTube introductory videos as well. So that's a resource. And then obviously there's marrying that up with the HD guides that are out there. Obviously you'll be aware of the HDA resources. I find that I use something from the HD Society in America as well. There's an understanding behaviour one, which can be quite useful, I think, for family members. And I find that the HD Yo brilliant also in terms of addressing some of the psychological issues that commonly arise as well. So I think that's the end of where our presentation and there's just some contact details for us. So I'm aware we haven't got too much time, but if we perhaps look at some of the questions, and thank you very much.